Kia ora. This short presentation is the introduction for the section on chronic obstructive pulmonary diseases, otherwise known as COPD. Chronic obstructive pulmonary diseases are made up of three main groups. We have people that suffer from asthma, an episodic disease, and although chronic, most people live with the symptom-free in between the various episodes. The other two main players are bronchitis and emphysema. And while we won't go into details, there are two other diseases that are well known to cause chronic obstructive problems within the respiratory system. One is cystic fibrosis and the other is bronchiectasis. However, today we are definitely going to be focusing on bronchitis and emphysema and their role in the symptomatic presentation of chronic obstructive pulmonary diseases. The reality is that most COPD sufferers are going to have both of these conditions. So the fact that they have a chronic obstructive pulmonary disease is because they're going to have comorbidities of both bronchitis and emphysema. The symptoms for these conditions can range from the very mild right through to the very severe, and it's going to depend on the progression of the disease. The symptoms associated with increased airway resistance include an increased work of breathing for the inspiratory and expiratory phases. The other changes we see with these diseases is a decrease in the surface area for gas exchange. The increased airway impedance and the decreased gas exchange is going to lead to a feeling of shortness of breath, in other words, dyspnea. And in both cases, physical activity or other stresses are going to worsen this. Most people suffering from these conditions are very likely to have an action plan, and this is going to help with their day-to-day living. And typically, these plans will involve both a long-term and a short-term bronchodilator to lower the airway resistance, and inhaled steroids that reduce airway reactivity. In severe cases, and with persistent hypoxia, low-level supplemental oxygen is used at home for these patients as well. So first, let's look at bronchitis. It's said to exist when a chronic productive cough has persisted for more than 3 months and has occurred in 2 consecutive years. You can research the principal symptoms in the timeline when you complete your illness script. The pathophysiology is related to a chronic or long-term irritation of the lining of the lungs. The most common reason for this is going to be smoking. You may recall from year 1 studies that epithelial, ciliated and goblet cells line the airway, and it's the constant irritation of these cells that are going to cause a long-term inflammatory response, and the net results are swollen airways that increase the airway resistance, dysfunction of the cilia that's going to prevent effective clearance of the debris from the airway, and an overproduction of mucus from the goblet cells that's going to further narrow the occlusion of the airways and will further increase the risk of infection. So the narrowed airways can produce a wheeze, and the excess fluid in the airways produces a coarser sound known as a rhonchi. Typically, people that are affected to a greater extent by bronchitis have been referred to as blue bloaters, and while not a characterization of the person themselves, the term does help describe 2 of the symptoms that are very, very common to people that predominantly suffer from bronchitis. The airway changes in bronchitis are likely to promote hypoxia, that is a low oxygen level within the bloodstream. This is going to cause cyanosis plus some local responses, and one of those responses is to increase the number of red blood cells. Essentially what we have is a larger number of red blood cells carrying an insufficient amount of oxygen around the body. And it's this increase in red blood cells matched to this insufficiency that's going to promote the presence of the cyanosis. So people are going to appear blue. The second local response to the hypoxia is going to be vasoconstriction of the blood vessels in the pulmonary circuit. What this means is basically high blood pressure within the lungs. And the right ventricle has to pump for year after year after year against this heightened pressure. It leads to right heart failure. And the right heart failure, in terms of the symptoms that produces, is going to be peripheral edema. And so the term blue bloater refers first to the blueness associated with the hypoxia, and secondly to the bloating or the increase in peripheral edema that gives us a very puffy appearance. You'll see the term cor pulmoni on this slide associated with the right heart failure. And cor pulmoni is a term that means right heart failure that comes from a respiratory as opposed to from a cardiac cause. The pathophysiology for emphysema is also related to an inflammatory response that's caused by constant irritation, such as smoking. Overall, the damage to the alveoli and to the terminal bronchioles reduces the available area for gas exchange. Essentially, an increased white blood cell activity releases enzymes that are going to create damage to the alveolar wall as well as the surrounding capillary beds. The principal changes are that the respiratory bronchioles and the alveoli are very prone to collapse and to trap air while a person is breathing out. So, despite being able to get oxygen into the bronchial tree, it's not able to pass into the bloodstream. And again, hypoxemia or this low oxygen state in the blood is going to result. At the same time, the carbon dioxide that's been passed into the lung from the venous blood that's returning can't pass across the alveolar wall. And so this carbon dioxide remains in the bloodstream. So unlike bronchitis, where there tends to be more airway narrowing, in this case, we've just got a loss of gas exchange area, and emphysemic changes tend to produce a quiet or silent chest pain. The terminology associated with emphysema or symptoms is the pink puffer. The terminal bronchioles will collapse during exhalation and this will trap air. They're very likely to have hyperdynamic inflation of their chest. At the same time, the carbon dioxide is not allowed into the alveoli to be breathed out, and so it builds up in the bloodstream. And this hypercapnia, this buildup of CO2 in the bloodstream, can impart a rosy colour to the skin. And hence they can appear quite pink. To combat this hyperdynamic inflation and the collapse of the airways, people employ a physiological response called auto-PEEP, which is basically to breathe out through pursed lips. And so the term pink puffer comes from the pink colour associated with hypercarbia, a hyperinflated chest, and having to breathe out through pursed lips. The paramedic focus for the management of chronic obstructive pulmonary diseases tends to be the symptomatic management of acute exacerbation of these conditions. Now, most people have some degree of comorbidity, so we might not be able to tell whether it's purely a bronchitic problem or an emphysemic problem. So we treat for both. And the treatment that we will employ, generally speaking, is going to be based around the use of bronchodilators, oral steroids, and where there is profound hypoxemia, oxygen. Which just brings me to a very short point where I wanted to discuss hypoxic drive. Hypoxic drive is a condition during which people that have got profound and chronic hypercarbia have a dulled response on the very receptors that are likely to initiate them breathing in. So these receptors are normally excited by increasing levels of CO2 in the bloodstream. But for people that have hypercarbia, chronic hypercarbia, these receptors become dulled and don't work very well at all. What the patient becomes reliant on is low oxygen levels to trigger breathing in. So if we go and add too much oxygen to the mix for someone that has that condition, we're going to fool these hypoxic sensors into believing that life is okay and that the person doesn't need to breathe in. So for a small subset of these patients, it can cause respiratory arrest, and it can be quite a difficult condition to reverse. And hence, our CPGs are constructed to reflect this in terms of how we manage oxygen administration in the setting of chronic obstructive pulmonary disease. So getting back to our main focus for paramedics, which is dealing with exacerbations of chronic obstructive pulmonary disease. The main reason we will see exacerbations of this is because something else has gone wrong and provided a physical stressor which worsens the COPD. Commonly, these are going to be a respiratory tract infection. So the illness script for exacerbation of COPD may reflect the fact that there's going to be a couple of days or maybe a week's prodrome of respiratory tract infections. These exacerbations can also be kicked off by pulmonary irritants. And I remember on one occasion being faced with quite an ill patient who had been involved in a motor vehicle accident, and while not being injured in any way, the airbag had gone off and the COPD exacerbation had been triggered by the talc in the airbag. For a small number of people, barometric or weather-related changes can kick off an exacerbation, and for many patients that we see also, worsening congestive heart failure, where it involves left ventricular failure and more fluid in the lung, can trigger an inflammatory response, which worsens the COPD as well. My point here around safety netting, when we manage these cases, is we have to manage the cause or whatever kicked off the exacerbation, as well as the symptoms of the exacerbation itself. So treatments starting at the primary COAN are going to be positioning to assist the respiratory effort and a decision as to whether supplemental oxygen is required. We can reduce any physical stressors, try and take the heat out of situations, perhaps get people into a quiet environment where they feel more in control of what's going on around them. And our mainstream management of the symptoms, as I said before, is going to be using an MDI or a nebulizer to provide short-term bronchodilator therapy, which is going to include the use of salbutamol and ipratropium. We use oral steroids to reduce the airway management. Now, these take quite a long time to kick in. It's a question of hours as opposed to minutes, so the sooner these are on board, the better. And if the problem is something like a respiratory tract infection or worsening CHF, we're going to have to work out some sort of management plan to address that as well. The information that you need in terms of the pharmacology can be found in Moodle in the pharmacology section. So you'll be able to review the pharmacological properties for salbutamol, ipratropium, and the oral steroids as well. And this brings me to the final point around some of our safety netting for these jobs. I feel for safe practice, it's very important to make sure that we've got a good grasp of what a respiratory status assessment involves. So we need to know what the minimum data set is that we have to get. We need to establish that as a baseline and base our future decisions on where that baseline is going. Where there are refractory and severe symptoms, we've got to move away from using MDIs and go to continuous salbutamol. And if we're not using oxygen, we need to use an air-driven nebulizer to prevent the hypoxic drive situation. An early call for assistance where things aren't improving. And what we're looking for here is someone that can provide treatments such as magnesium sulfate, anti-anxietal management, the provision of CPAP, or the administration of adrenaline in the most critical of cases. If the case should be going the other way and we're considering non-transport, then non-transport checklists need to be completed at the house, not as part of a checklist that we use to do our paperwork afterwards. And so things that are on the checklist, like excluding other serious condition, means that we must have run through the differential diagnoses with the patient. And another great safety netting for paramedicine these days is if we can't get people to see primary care within 12 hours, we can sometimes refer them to an ECP. Okay, well that concludes our whirlwind tour. I'll see you for the lecture and the longer version, and I'll see you in the workshops when we practice the physical skills for management of these patients. Ka kite.